The first thing that we ask our nurses to do is really advocate for their residents not to get those antipsychotics. So in facilities where we're really successful, we find that we reach a point where the nursing staff actually saying we shouldn't be using that drug, as opposed to the providers saying we shouldn't be using it and the nurses are asking for it. So that's the ultimate goal for the nurses, to reach a point where they feel that the use of antipsychotics in a dementia patient who's not psychotic will ultimately hurt that patient's care. The other piece is involving the CNAs. So just like the right hand of a physician is always a nurse, the right hand of a nurse is a CNA. And if the CNAs are not on board and they're not understanding why we're doing what we're doing, how we're doing it, it doesn't work. And also, when we're not doing antipsychotics, we defer or we fall back on the non-pharmaceuticals. The non-pharmaceutical interventions, I would say 99% of them are the CNAs. So the CNAs need to know what to do, why they need to do it, and how much we're depending on them to do it, for them to be an integral part of the team and to push for less medications. One of the things we find is that when we reduce antipsychotics, residents perk up, and the CNAs need to be aware of that, and need to expect that, need to be okay with that. And when a dementia patient is perked up and awake and walking, they're going to wander in people's rooms, they're going to do things that are not necessarily convenient, but with the understanding of CNAs of that situation, of saying this is what dementia patients do, we would go a long way in terms of reducing antipsychotics.
What do physicians need to know?
What do physicians need to know about the issue? I would say that the first thing that they need to know is that part of the problem is that the healthcare system is pushing physicians in this issue to be rubber stamps. So a physician needs to know that that rubber stamp protocol, where we're called and we're asked, can we have X drug? And we say yes because we want to be nice, and we want to be, part of the team, and we want to be good, and we want to go back to sleep at 2 in the morning. That's not helping that resident. And so for patients' sakes, and it's part of our oath to do everything we can to improve the care of our residents, we need to learn how to say no. And also we need to work very closely with our leadership at any facility that we work at. Because we could be doing education over the phone at 2 in the morning all we want, it won't work. The administrator, the DON that comes in the next morning needs to know exactly what went on with that resident in order to go and do interventions for the next time. It's okay to say no when it's clear. We do that on other issues. If we're asked to prescribe antibiotics for a viral illness, we say no. So why is it okay to say yes when we're called for antipsychotics? And also, we can't teach what we don't know. So for physicians who are doing geriatrics kind of as part of their bigger practice that involves family practice and internal medicine, they need to know the importance of this issue for those residents. And they need to spend the amount of hours to learn about it, to stay educated about it. I myself am trained in geriatrics, but I find myself learning on this issue every month. And it's the trajectory of increase in information is really very steep. So we can't just sit back and say, okay, we know all we need to know. Physicians need to seek more information and to understand why we don't need to prescribe antipsychotics in the majority of cases. Now, the other thing that physicians need to know is that just because CMS says it's a bad drug and we have a black box warning about it doesn't mean that it applies to 100% of the cases. We do have cases where you have acute delirium. Now, I've seen hospitals treat acute delirium with antipsychotics in the absence of psychotic symptoms, just because that's what the book says. Reality is some deliriums have psychosis, some don't. So in a delirium case where you have psychosis, it's very important to actually treat it and to use antipsychotics in that 1% of the patients. But that 1% is very different than our current percentage, which is up to 30% in some cases. And that's an overshot. So any physician or medical director in our state, at least, can call the Maine Medical Directors Association if they have concerns about how to do the right thing, or they have issues implementing. They're trying, for example, to reduce antipsychotics, but they happen to be getting a lot of calls that ask for them. Or any other issue related to the topic, they can call the Maine Medical Directors Association. Nationally, luckily, there's plenty of resources. So the National Medical Directors Association now has changed its name to Long-Term Care and Post-Acute Care. They have conferences annually that part of the workshops would deal with that. There's plenty of online information. Even I myself did an hour over this issue in details for physicians to go over our CALM protocol, which is to reduce curtailing antipsychotics in long-term care medicine. So it's a phone call away, it's a click away on the computer. There should be no excuse for not finding it, and a lot of people are willing to help.